Baco Diagnostics continues their commitment to educational initiatives that propel the profession forward. Baco Diagnostics, more than just a pathology lab, they're your professional partner for podiatric pathology and therapeutics, helping podiatric physicians keep America on its feet.
Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm with my co-host, Dr. Johanna Richey. Hello, Joe.
Hi, Jeff. How you doing?
I'm doing great. Good to see you. How was your weekend?
Good. Kids are back in school, so it's been all the hustle and bustle around first week, getting everything into that routine. So it's been good.
It's always good when you need a break to go back to work, you know?
Indeed. It's very much how it feels.
Well, we have a phenomenal guest today, certainly an icon in our profession, Dr. Don Green. Dr. Green, welcome to Dean's Chat.
Well, thanks, Jeff. It's nice to be here. Appreciate you having me on.
No, we're so glad you're here. If it's okay with you, Dr. Green, let's go with first names, Don, Joe, and Jeff.
Great.
All right. Well, let me give you a little bit of a formal bio or introduction here. Dr. Don Green went to the California College of Podiatric Medicine. He then did a residency program at Jewish Memorial Hospital and did his second and third year of residency at Doctors Hospital in Tucker, Georgia. He has been a longtime leader in our profession. He's been the president of the American Board of Foot and Ankle Surgery. He was the program director for the Scripps Podiatric Surgical Residency Program. And we'll also get to talk a little bit about your educational experience as the chair of the Department of Surgery at the Pennsylvania College of Podiatric Medicine, which is now Temple. You've got a storied career. We've got no shortage of things to talk about, Dr. Green, or Don.
Thanks.
Joe, the floor is yours.
Yeah, thank you so much, Dr. Green, for coming on. I will have to really adjust to calling you Don, just from the little bit that I got to know you when I was a student rotating through many, many years ago now. But I'm really excited to have the chance to interview you to really help talk a little bit about the history of the profession. So I think the first place I would love to start is if you can talk a little bit about what your experience was like after you graduated residency with Doctors Hospital in Georgia. Did you go immediately into academics, or what was your transition from residency into career? What did that look like for you?
Well, it's an interesting time because it was back in 75, and there was a new podiatry school starting on Long Island called Stony Brook. And I was told one of the instructors that I had was Tom Scarlato in Biomechanics when I was out at the California school. And he had taken a position at this new Stony Brook podiatry school and said, listen, unless something unusual like New York City going bankrupt, we'd love to have you come on board. So I was set really to go teach at Stony Brook. But I don't know what you wouldn't remember, but New York City ended up going bankrupt and defaulting on some loans that they had. And part of that consequence was that Stony Brook never really took off as a podiatry school. So I just spent 6 months traveling around the United States and just being able to read fun books. I mean, I was reading a lot of academic books, but it was just fun to read novels and stuff that you didn't really need to have. So I went around for about 6 months and looking for certain places to practice. I was thinking I might end up going back to Northern California, outside of San Francisco, and possibly teaching at the school there. But I then got 3 different offers, and they seemed to come in threes. And one of them was to teach at the Pennsylvania College of Podiatric Medicine. And at that time, the chairman of the surgery department was Guido Laporta, and he was leaving to go back to Scranton, which is close to Binghamton, where I grew up. And so I ended up teaching there, and eventually stayed for about 8 years. And it was a nice situation because they had people that could film things. And so certain surgical aspects or certain things that we could work on we had someone to take that responsibility. Plus, they had a gait lab, and I was interested in the biomechanics aspect as well. So it turned out to be quite a good situation. I ended up becoming chairman of the surgery department and worked in the biomechanics department, which they called orthopedics department. So it was good for about 8 years, and we had a great surgical group. We had someone from North Lake, which was in Chicago with Smith and Weil, and someone from Kern, which was another hotbed for residency programs. We had someone from the California School of Podiatric Medicine, did his residency there. And we had a local guy who was trained by an orthopedic surgeon who was son of a podiatrist in the area. So we really had a group of young guys that were teaching at that time. So it was really fun to have that surgery department come together. And then we had a couple guys in biomechanics. Harold Schoenhaus was chairman of that group. And we had 2 days that I was in the biomechanics department, or 2 half days I was in the biomechanics department, and then two of the people from biomechanics came into the surgery department. So it was quite an interesting way to interact and handle the two departments together.
Well, that's fabulous. May I ask you a question about Doctor's Hospital at the time? I mean, to go there and spend time there, you actually have no choice. You've got education infused in your blood. Tell us about the impact of being at Tucker and Doctor's Hospital on your career.
Well, the first year I spent in New York City with a fellow by the name of Marvin Steinberg.
Oh yeah, John's grandfather.
Yeah. Now he never did any biomechanics, and he made fun of it. He didn't do any palliative care, and he didn't really do surgery. Occasionally he'd do a surgery. So what did he do? I mean, he was a diagnostician. It was a fabulous year because he was a diagnostician in podiatry. He had his own, some part of the lab that he'd spin down blood, and he was just a great guy from a standpoint of knowledge in podiatric medicine or medicine in general as it affected the foot. He was a guy that in his time would spend 3 months with the internist, who is a fabulous internist in New York City. He said, I just carry your bag. I'll pick you up. I'll take you where you want to go if you just let me learn. He did the same thing with a pathologist, a neurologist. I mean, this guy was very unusual and an interesting guy, and was even doing research while we were at the residency program. He had 4 residents, and he was doing some malignant melanoma research with rats. So it was a very interesting guy because it was a time that was advanced from what we had seen in the past. My dad was a podiatrist, and so it was interesting to see the politics of what was going on. But Marvin Steinberg was a scientist, and it was great to see some of the patients that came in that were, you just didn't see in that type of podiatric practice. So I'm sure that that's where John got some of his inspiration as well, although John's dad was a podiatrist too.
Yeah, and his son, Reed, is going to podiatry school next year, potentially 4th generation.
Ah, very nice. But you really asked about Doctor's Hospital in the 2 years, and it was a great 2 years because I ended up spending the time with E. Dalton McGlamry, who was, one of the leading podiatrists at the time. And he was very interested in teaching what he was learning. He was trained in the military, I think it was the Navy, and he wanted to give back to the profession. So he was doing a lot of scientific things in the state. And then eventually he started lecturing outside, and he lectured in California. And my brother, who's also a podiatrist, was involved with the local podiatry community at that time as past president. And they had Dr. McGlamry come out and give a lecture, well, a day of lectures. And I think we were probably the first ones that had an annual Doctor's Hospital podiatry seminar that was co-sponsored by the local society. And it's probably 35 years now that we've been doing that in San Diego. And so we still do it every year, and they help. So it was a great advisor or teacher or mentor. And because of his interest in teaching and making sure the profession came along with him, it instilled in his residents. And so they're continuing to do Podiatry Institute lectures. He started the Podiatry Institute, and it had its own separate building, and they had facilities for slides at that time, and movies and stuff. In fact, for one of his Christmas presents from his partners, he got a camera, and so he was doing a lot of the photography himself. But it gave me an opportunity too to put some movies out regarding biomechanics and the function of biomechanics. So it was it's a very nice atmosphere that I got into, and I was very lucky to be able to do it.
And what was your relationship when you were there? Where were you in relation to when John Rook was also there?
John Rook was my junior resident.
Okay. Yeah.
So he had gone to Northlake, which is in Chicago at the time, and his was primarily a surgical residency, and mine was more of a medical rotating. We had rotations on plastic surgery, on medicine, and it was really more of a rotating. We had some surgery, but it was not quite as extensive as his was. And so we came in, and he had a year's of surgical experience on me, and I had a year of general medical on him. So it was kind of like symbiotic to some extent. But then he ended up getting attacked in the emergency room and hurt his knee. So he's out for a couple of months. So it was really kind of like, well, I had 2 extra months or 3 extra months to catch up from a surgical standpoint with him. So it was a very interesting time.
Absolutely. And it's interesting as some of the things that you've experienced when you talked about the videos and having the faculty appointment and hearing you describe the kind of development of that interest in terms of teaching and using multiple resources. I know, so one of my dear friends from school was one of your residents. So you were also the residency director for the Scripps program in San Diego was it 1980s? Is that when you started there?
Yeah, 1984, I
Okay.
left school and came out and went into practice with my brother here in San Diego.
And so as the residency director, which will kind of maybe shift a little bit toward that part of your career, you had created resources and videos. So my friend was Nate Jepson and Josh Boone. So that gives you a little bit of a reference in terms of where I fell in the training spectrum there. Ben Cullen was just 1 year below me. He's younger than I am. So again, just to kind of get the ranking in terms of where we sit. But some of the resources that the Scripps program had provided to their residents, again, in terms of video support, academic support, attention to detail when it came to radiology rounds. Can you talk a little bit about your teaching style and how that evolved from the faculty position to then into the residency director position?
Well, I was residency director during a period of time when I was at the Pennsylvania College of Podiatric Medicine. And I think maybe one of the reasons that I was able to get the program in Georgia was my senior year. They had a fellow who was Mort Wittenberg, who was at the University of Georgia in Athens, and he wanted to demonstrate that orthotic control and biomechanics could change and show that it could change the way the foot functions. So they had a unit that was like an X-ray unit. I think it was for diagnostic stomach and throat kind of things, where they'd put a dye in there and it could take it. But so he wanted to show that this worked, and he built a couple of transport individual things they put together and blocked them. So we had a little runway. We had to turn this machine on its side, and we could only get one step that would take an X-ray view. So we had these patients practice and walking so that they would end up hitting in the center of this step where they could take a picture of the foot in motion. And so we did that, and we had 3 or 4 different individuals. That one was a flat foot, one was a relatively normal foot by an extern, And you would know probably Barry Skirren. He was an extern at that time, and we had one of his feet and one of my feet, and then this radiologist who had a very severe flat foot. And so we tried to show how the foot moved, and then how it functioned in gait, and then how it functioned in shoes, and what the difference of it. So we would get 1 or 2 good pictures, because you didn't want to have a lot of radiation, of a step. And then Montgomery had some insight to the CDC that was down here. And one night I went into the CDC, and they had a machine that I could take a picture of one frame. And I could take 3 pictures of it, or I could take 5 pictures of it, and I'd move to the next frame and do it again. So I could get a slow motion. This is, back when we didn't have all this, this technical stuff. And we were able to make this movie of the foot in motion, which showed supination and pronation of all these people, and then showed them in gait, then showed them barefoot, and then showed them in gait with their shoes on. So because we were able to do that, and those facilities were there, I think that was one of the things, and this was as a student. So a year and a half later, when I was applying to their 2nd year program, I think that helped a lot. So my interest in biomechanics really kind of helped, I think, get to me where I was supposed to be. Now, the question that you asked was about the residency program. So I had been teaching for 8 years. So over that 8-year period of time, I didn't have any formal training in education, but I ended up figuring out how to do slides, how they were supposed to be done, what was a visual, auditory learner. And then over the years, we helped with the residents, because they had to do a research project their 1st year, and they had to do a research project their 2nd year. This was after a fashion, because we started with a 1-year program at Hillside Hospital. In the 90s, we had a 2-year program, as we added some clinical experience through, I think it was Kaiser at first. And then we went to Scripps Green, which was another place so we had 3 I guess it was 3 2nd-year programs. And then it went to a 4th when we went to Sharp, which is another group of hospitals here in San Diego. So we had 4 residents per year. We didn't have enough rear foot at that time. So 2 of them went to Sacramento, Kaiser in Sacramento. And when we went to the 4th one, there's a Kaiser in inland Los Angeles area. And so we do have 4th year, 1 stays with us, and 2 go to Sacramento, and 1 goes inside like Riverside or in that area. So that's how our program grew. And from a teaching standpoint, we are still having the PI Institute to come out every year. So the resident had to do a research project and had to present it. So I was kind of more involved in teaching the resident how to teach both visual and auditory learners. And so I had to develop my teaching skills as well. And now we have a list of things that they're supposed to do. And each of the residents, we have eight now, because we have 12 residents. So the 1st year they do a research project, and then the beginning of their 2nd year, they have to present. And then the 2nd year residents research project, they have to present in their 3rd year. So we have 8 per year that have to go. So that was part of what I needed to do besides running the residency program itself. So it's interesting.
And where did you go to learn more about how to teach? Because you're right, it's interesting. The majority of the physicians that are in teaching roles don't have formal experience or education in how to teach. What were some of the things that helped you, or mentors that maybe helped you along the way?
Well, I think the Podiatry Institute that Montgomery had started really helped, because partway through that, we moved from slides to the computer and PowerPoint. And so being out here in San Diego, I didn't really have any experience with PowerPoint, and it was a learning process. It seems pretty simple now, but at the time, you do one thing and you don't have someone to tell you how to correct it. It was very tough. So I was very fortunate in that the Podiatry Institute has a couple of people that are involved in doing the slides or doing the PowerPoint, and they helped me to transition into doing the PowerPoint. So I probably wouldn't be lecturing anymore had I not had that help, because I was in that transition area where I was in my 50s, and did I want to do that and learn all that stuff? Because if I didn't have someone to really help, it would have been very laborious. So that really kind of helped me, and it was kind of nice to have that background.
You know, Don, I noticed in 2003, you were the Educator of the Year, an award given by the California Podiatric Medical Association. I imagine you remember that. That's a great honor.
Yeah, it was a very nice honor, and it was probably because I was lecturing. You know, after being chairman of the surgery department, I did get an opportunity to lecture, and then certainly got the opportunity to lecture with the Podiatry Institute. So I was lecturing throughout the country, and certainly lecturing, doing the residency program, and trying to foster additional residency programs in the area as well. So it was a very nice honor. Um, it was kind of after that in California they were trying to make podiatry acceptable as a primary care equivalent as well. So a lot of the people that were working on that came down to the residency program to see the rotations that we had, because we had rotations. The first year was mostly rotations on emergency room medicine, infectious disease, internal medicine, pediatrics, pathology, radiology, et cetera. That was more generalized. They did get some surgery as well that first year, but really the second year was the time that they got their counts. You need to have so many of each surgical procedure. And then the third year was where they really got to do a lot more of the rear foot stuff and the ankles. And so it was one of the programs that they had this group that was made up of MDs and podiatrists come around to evaluate to see whether we did have an equivalent. And they said that it was pretty equivalent with two exceptions. One was OBGYN stuff. Of course, we didn't really think we needed it. And the second was psychology. Now, the hospital itself has internal medicine residents, and they don't have a psychology rotation because of the makeup of the people that we see. There's a lot. It's a #1 trauma center, so they get certain people that come in that they have to deal with that, and so they felt that that wasn't necessary for us. We had to set up a rotation with UCSD where they had a psychiatry rotations they go through, and we set up a rotation with family medicine so that they would get with emphasis on the OBGYN, female health kind of things. So we were able to say, yeah, well, they're getting that now. So it was pretty much universal that in California, they said, yeah, you can do your own H&Ps at that time. And you're trained to do it like everyone else. You had so many cases, et cetera. So that was one of the things that the residency helped us with in the California situation, where we learned that we could do our own H&Ps. So that was nice.
Very good.
Can I ask another question, Jeff?
Sure, go for it.
I'm like, just so many fun things here. And again, it's just really neat to hear the progression of the profession as we kind of look back through history. Another thing that I know you were involved with was past president for the American Board of Foot and Ankle Surgery. Can you talk a little bit about your presidency, maybe any of the challenges that you either mitigated or had to manage while you were there, and kind of what the pulse was in the profession at the time?
Well, I think I had 8 years there on the board, and of course, the last 2 were vice president and president, and it was a very interesting time. I think I started while I was still at the podiatry school in Pennsylvania, and it was a matter of finding out how we credentialed applicants and how much their training had to do with whether they're eligible or not. And I think when I started, not everyone needed a residency program, even a 1-year program. So there were some 2-year programs at the time, back in '72, but I think there was only one 3-year at the time, and that was second and third year with McGlamry down at Tucker. So that was an interesting way to try and make sure we got more residency programs, that we set the minimum bar of, yeah, you need at least 1 year residency. And then it became, yeah, you need at least 2 years of residency. And then finally, and it was more financial, that you needed 3 years, because if you required only someone to practice with 2 years residency, government wouldn't pay the 3rd year. Now they did for a while because they felt it was necessary, but it got to the point, if all of them weren't 3 years, then the government wouldn't cover it with Medicare, like they do the other residents. So that was part of what we were working on, is to make sure that we had residency programs, that they got to be 2-year programs, and that they were required to get certain specifics. They had to have at least a certain number of cases. They had to have certain rotations that they needed, and that progressed over a period of time. I had a little bit of experience with this kind of thing because my dad, as a podiatrist in upstate New York, was involved in the politics, national politics. Because at the time, California and New York and Texas were the 3 largest groups, and they had a lot of control. And at the time, they were trying to change chiropody to podiatry. And it was very interesting because there were people that were fighting that change. And so they had a vote in the national election, and my dad was very involved in trying to make podiatry more scientific. So they didn't have the votes. There was about a split, but they didn't have the votes. So the guy that proposed the amendment or the law voted against it. And all of his cohorts couldn't figure out what he was doing. But they used Robert's Rules of Order. And if the person that submitted the law or the change didn't vote for it, he could bring it up again. But if he voted for it, they couldn't bring it up again. So he voted against it, and he told them why. They went around, they finally got the extra vote they needed that night for some kind of pressure. And that's how it passed. That's how we came to be podiatrists rather than chiropodists at that time. So I knew that there were things that you could do, and sometimes it took a slow progression to get to that point to convince enough people. But that's kind of what we were doing at the time, and getting the certificate. There was also a group at the time that wanted to get a certification for non-surgical podiatry, and that's how the second certifying board became possible. Because they said, okay, you can be certified and you can be in the hospital, but you can't, it's not a surgical certification. So that was somewhat different. So it was interesting, some of the compromises you make as you go through, and what you needed to do to get things done.
Does politics continue to come around like a swinging pendulum, right? I mean, look at our profession right now with certification.
Right. And it's interesting because recently the Biomechanics, it's no longer called Biomechanics board anymore. It's the other certifying board wanted to do surgery.
I know, that's what I mean. Yeah,
That's
created a big
problem. Well, from the history, they only wanted to be able to be certified so that they could be certified not to do surgery. And now it's like they wanted to do surgery. Well, to have 2 certifying boards in surgery was kind of crazy. People wouldn't understand that because you don't really have that in the other professions. So, yeah, things come around and people change, and different people are in different positions. And so it was interesting knowing that history and then saying why this is not logical to have 2 surgical certifying boards.
Don, did your father have an opportunity to work with Earl Kaplan in a lot of the political realm of the profession?
Yeah, he had a chance to work with Earl Kaplan, and there's a surgeon in California that at the school had a hospital, a small hospital associated with it. So they had surgeons there. So he had a chance to work with McGlamory. McGlamory is a very young guy. He's much younger than my dad was. But they had kind of worked together because that was part of the situation with him. They had a program called AC-Ducey because all these small states didn't understand that didn't have any power. So any state that only had 1 or 2 representatives went to the AC-Ducey, and these guys would get together and they would decide on a problem, and then all of the people had to vote the way that the majority decided. So they became strong too. And that was part of Georgia where McGlamry was. He was one of the AC-Duceys. And so it was very interesting to have that kind of background that people don't have the background now. I mean, the students graduating now, they think, well, of course we should be doing surgery. Of course we should be doing H&Ps. And of course we should be doing all this stuff. And they don't realize the fight that we've had over the years. And for me, by extension, the fight that my dad had over the years to do the political aspect of it. And so it gives me a better perspective, and you can't expect them to have the perspective, but they don't have it. It's unfortunate, but they just don't have the perspective because they didn't live through it.
And I think you're passing it down through your residents, though, because when we interviewed Ben Cullen, he was talking about advocacy within the state and getting the other residents involved. So I think once you get involved in that, it's easy to, not easy, but people at your training also develop a similar interest to advocate for the profession.
Well, we're very fortunate to have Ben come into our practice. He wasn't really trained at our program. He was trained in the Bay Area and had great recommendations and a hard worker. And it was very nice to be able to turn over the residency program to someone who was as skilled as he is and is passionate and how well he's done. We actually brought him in to be another partner to take over a period of years. But we were very fortunate to have him take over the program. And he's just, it's always nicer when people that you work with kind of take over and then they outshine you. So he's done a great job.
No, that's fabulous. Speaking of your practice, we talked beforehand about that you had a large practice with your brother. Was there, and your father was in it too, right? The three of you? Was that
Well,
right?
yes, he was, but he practiced in Binghamton, New York, and we kind of thought that we might go back and take over his practice, but you have to live in Binghamton, New York to do that. So, I mean, it's really snowy and cold in the winter, and it's hot and muggy in the spring, and it rains a lot. And then in the summer, it's hot and muggy. But there's 2 weeks in the fall when it's just gorgeous. But 2 weeks was not enough for us. So, yeah, my brother was more politically oriented than I was. I was a little bit more scientific, I guess. And he was pretty well known politically in the state by the time I came out. So he had a partner. His partner had developed another practice in a surrounding area called Poway, and he was getting too busy in both practices. So when I left the school, I came out and purchased his part of the practice, and therefore worked with my brother from that point on. And it was pretty good. Our personalities are different, so we kind of got along pretty well, not stepping on each other's toes. And I was a little bit more known nationally. He was very well known in California. So it really did kind of work out well. Yeah, it was fun.
Back in the mid 80s, as you and I discussed, my mother had her bunions done by a podiatrist in Madison, Wisconsin, and my parents spent half the year in San Diego. So my mom was one of your patients like 35 years ago, and she loved going to your office. She said it was a fine-tuned machine.
Oh, thank you. I remember the patient that came in. I didn't know it was your mother, at the time, but we did have referrals periodically throughout the country.
Yeah, and you all treated her so well. She really enjoyed going to your practice. So thank you.
Well, thanks for that.
Joey, the floor is yours.
Yeah, I don't know if we're going to take a little break for a word from our sponsors. And then when we come back, I do have some questions for you, Dr. Green. Again, kind of focused on residency, education, and maybe some advice you have for the younger generation.
Okay.
For sure. Well, let's do a quick shout out to our sponsor, Bako Diagnostics. We all know that early detection is the most important determination in improving patient outcomes. Bako Diagnostics remains committed to supporting you in your role as the first line of defense in diagnosing lower extremity pathologies. Bako Diagnostics, helping podiatric physicians keep America on its feet. Don Bako has been a tremendous sponsor of ours, and as you know, they're at all the CME programs around the country, and really educating students and residents alike, and then practicing docs. So they're our sponsor.
Well, that's kind of nice because I know when they come out and they are a big part of the Podiatry Institute as they give lectures throughout our seminars throughout the year, and they usually give about 8 to 10 a year, and they lean a lot on their graduates to present and give lectures. So it's very nice to have them as part of able to do the educational aspects that we've done that you know, we're following what Dalton Montgomery had done himself and recommended.
Dr. Green, you know, when Dr. Weed was lecturing and you were following along and getting it, you felt like, wow, something must be wrong with me. Remember, he was doing all this stuff.
Yeah. Well, no, the question that you asked was, what's changed in education in the last few years? And I was beginning to talk about the biomechanics in the last 10, 15 years was one of the bigger changes that I see. I was fortunate enough to be trained by Root, Weed, and Scarlato, and a clinician by the name of Chris Smith, who was really the biomechanics clinic teacher that we had. So it was very interesting for me to be able to go through that and understand the function of the foot and how you can control the function of the foot in the early stages. And although it turns out that not everything that Root said was true, but what he really gave us was a basic understanding of the foot function and something to be able to use scientific language to communicate with each other. And then, I don't want to say attack, but then see what was right and what was wrong, so we could have a scientific basics for where we are going on. So some people have said, oh, no, he was very dogmatic, and some of the things he said weren't really correct. And I would agree with that. But at that time, he was the guy that was doing the research or following the research and doing the clinical training. And of course, he's not going to be all right. We're all going to grow and learn. So for me, it was for him as the father of biomechanics. And then they wrote the book. Weed, Root, and Orion wrote the book, which was great because we didn't have any literature for the clinical application. So it turned great, and I got very interested. I had a friend, Mike Burns, whose dad had a lab, and he was interested in it too. So we had kind of a lot of discussions on it. And but I was interested when Weed was one of the primary teachers, and I loved it when he would talk, but he would go off on tangents when someone would ask him a question. They didn't understand it. I was able to follow him pretty well. But when he went off on tangents, it was also interesting and I could follow it. But some of the students that didn't kind of have that understanding felt that he didn't finish his thought process, what he was doing. And he was a great guy. He was really willing to try and sit down and teach people. He'd take his time, and a great teacher. And certainly he died much too early with not having him around to teach some of the other students. But from my standpoint, the last 10 or 15 years, there's been a real emphasis on surgery, trauma probably too, and a de-emphasis on biomechanics. I see the students coming in now not having a real understanding of the basics of biomechanics. So it's unfortunate because we saw in the last 10 or 15 years, research is being done by physical therapists. Some podiatrists in Australia are pretty good at it. Some in England are, but and we certainly have teachers that are good. Doug Richey, for instance, and in California, and Kevin Kirby in California, and there are some throughout. They have a biomechanics seminar in New York that is a Schuster honorary Schuster seminar, who was teaching biomechanics in New York. And I had a guy who was Alan Whitney, who was New England trained biomechanics, and at Pennsylvania College of Podiatric Medicine. It took me about an hour to discuss any comment with him because the terminology was so different. But once I got through it, then I could see his clinical expertise, and we agreed on a lot of stuff. And it was very interesting to me to have that perspective as well in my training. So I think we've lost that biomechanics aspect. And even if you're doing surgery, biomechanics is essential to understanding what you're doing, why you're doing it, and to be able to follow them up. The difference between the general bone doctors and podiatrists is podiatrists oftentimes see the patients for longer than what an orthopedic surgeon would. He does the surgery and says, okay, you're all right. Well, we follow the patients and we try and control the function, and we see them for a longer period of time. So our outcomes can be seen a little bit better for a longer duration. And if we have residencies that do research, they can go back and say, hey, this didn't work, this did work. So it's a big advantage, even if you're thinking you're just going to do surgery. But I think we're giving up that part of the profession to maybe physical therapists, or maybe there's going to be a new podiatry or chiropody group coming in that's going to handle that. It's too bad, because it's an intricate part of podiatry, and it's not that you're losing money seeing these patients and making orthotics for them, or it's an intricate part of podiatry, or has been. And I think we're losing it. And I don't think they're getting the biomechanics necessary in many of the residency programs. So if you did get it in school and you don't have it for 3 years and then you graduate, it's a little tough to get back. And I think that's the biggest concern I have in the changing of our education. We're very much better trained about the whole body. We can do H&Ps. We're trained at medicine how it relates to your foot, much like Steinberg was back in the 40s and 50s and 60s. So that's important, but to give up biomechanics is kind of very sad in my way of thinking.
I agree. We make a special effort at the college to lay a foundation and a progression where they know their lower extremity anatomy, and then they go into biomechanics, and then how that is applied to surgical selection and procedures. But you're right. I think sometimes when they're out on rotations, they lose a little bit of that, because they'll go to an office and they're just dispensing prefabs and things, and not really doing the biomechanical workup. So I think it's a challenge for the students, because they're a little bit confused.
I think it's a challenge for the schools, and I think it's a challenge for the residency programs as well. If you want to give up that aspect of podiatry, okay, give it up. But it's a big part, and it's very intricate in understanding the foot and function and controlling them after surgery. Surgery is not the end all. So for me, that's one of the things that we strive in our residency to make sure that they understand it. We lecture on it. We try and have them watch each other as they're walking, what deformities they have, how come this happens. But it's harder.
Joe, I was just thinking, listening to Don, we could put snippets together of leaders in our profession, from Dr. Blake, Dr. Kirby, Dr. Richey, Dr. Ruck, yourself, talking about the need to emphasize biomechanics, because it's a recurring theme.
Yeah. I think there are some schools that are better than others that can kind of teach it, but I'm finding that the student applicants for the residency program, there's a lot of, and we usually get, from the top half of the schools. I am very concerned about the rest of the students that aren't as good as these are, and I think we've lost a lot in the last 15 years, and I don't know how to correct it, but it is something that I think needs to be re-emphasized, because it's an important part.
Absolutely.
Very much mirror that.
Yeah. Joe, your thoughts, final thoughts?
Yeah, I'll just say, unfortunately, our students have to suffer through listening to me talk for probably about 3 hours on surgical pathomechanics on Flatfoot on Friday. So I fully appreciate everything that you're saying, Don, about the way that we approach biomechanics in our training, both academically and in skills in terms of residency training. There's some opportunities for improvement there, and again, the things that I think are exciting opportunities in the future to maybe bridge some of those gaps. So I guess my last question for you is advice that you would give to future students, current students, about how they can advance their own career? Like, what are the things that either make them stand out as applicants, or maybe in this little conversation we're just having, brush up on your biomechanics so that you can stand out, since that seems to be maybe an identifier out there. But what are your thoughts about words of encouragement and advice?
Well, I think it's pretty much what you would think. If I asked you or the student, what would you look for in an applicant? They pretty much know it's someone that's worked hard, is willing to be an individual that cares, that personality is a lot from it. Not that you have to be a great personality, but you have to not be a bad personality. That's the kind of thing. If you're just in it for yourself, it's going to show. If you're not willing to help your fellow residents, if you're not willing to help your patients, it's going to show. And I think for us, because we get a high level academic aspect of our applicants, and we do know certain people at the different schools that can give us input on individuals. It's not always the top of the class that's going to do well. It's knowing how they interact with people, whether they care, how they demonstrated in their life they cared, and are they willing to give back? It's an opportunity that they've had. It's an amazing opportunity to go through 4 years of podiatry and then 3 years of residency program. And it's if it's taught by people that are interested in giving back to the profession, that's going to be something that is important to give back once you get out, to repay what you've had the experience of obtaining. And podiatry is such a great profession. I mean, I think medicine is having problems now where if you're primary care, you have 10 minutes to see a patient and that's all you can do. And it's not like it was in the old days where you're told by either your insurance companies or your group or what have you that you have to do this many things and that many things in such a short period of time. You don't really have the luxury of saying, okay, I'm going to set aside a half an hour instead of 15 minutes or 20 minutes for this patient. When you come back, I'm going to look into it a little bit more deeply because it's an unusual case or something. So it's a little bit harder. When you're in private practice, you can do that. You just accept a little less money. So, but if that's what you want to do, that's okay. Whereas in the groups, it's a little bit harder to do that because we're paying you for this, or you're getting this reimbursement for that, and here's the time. And if you don't do this, you won't make partner, or you won't get this, or you get. So it's changing, and it's a little bit harder for people to still be able to do the private practice and have a little bit more control of their profession. But for podiatry, it's a great profession. You can do a lot of surgery, you can do a little surgery, you can see a lot of patients, you can do biomechanics, you can do surgery, radiology is a part of it, pediatrics is a part of it. You can specialize in those areas. If you're in private practice, you can take time out of your office to go with your kids to their soccer games or what have you. I think podiatry sometimes is getting more into okay, you're in this group and you have to do this, and you can't do that quite as well, taking off a half a day if you want to. You just don't have that as much an opportunity. So I think for people that are getting into the profession, it's still a great profession. You still have a lot of ways you can go. You can set your own time. If you want to do trauma, you can take call, and you take call with several other people, and it's a high pressure kind of a instance that you got to get to that level and then stay at that level. Or you can do rear foot and elective rear foot and forefoot stuff, or you can just do forefoot stuff, or you don't even have to do surgery. You could specialize in radiology. Now there's 1 or 2 or 3 or 4 people that can do that. There's not a high opportunity. You can specialize in pathology. Harvey Lamont was a guy at Pennsylvania School who really specialized in pathology. He went to Hahnemann, which is one of those 5 medical schools in Philadelphia area, to see if he could get on staff. And he walked in one day, and the guy says, okay, there's 6 or 7 different microscopes set up here. You tell me what you think. Oh, he says, that's fine. So he went through and told him what he thought. He says, okay, you can get on. But I mean, it's because he was specializing in that area and he knew the area. And so there's a lot of opportunities, but you need to make sure that you study and you learn and use your clinic as a questioning spot for your professors. If someone says one thing, another one says another, well, the clinic is your opportunity. If it's biomechanical question, well, you go and have one attending explain to you what he thinks about the biomechanics. Have the patient back in 2 weeks and have another clinician do it. So that's your way to be able to tell whether what they're saying is true or not. So that's your opportunity to explore and see if people are telling you what's the right thing. And of course, we've learned over the years, we've been taught some things that turn out not to be exactly true, but because you've learned in the clinic, you've had a baseline and you can say, yeah, maybe it's not quite as true. So you have to have an open mind, a questioning mind. You have to be a nice person. It doesn't have to be a personable person. You just have to be not a bad person that's going to create problems. If you ever had a resident that turned out to be a real problem, you know that that's 3 years of a tough time. So we try and find out people that are going to be able to be giving to others and work together to be good for everybody. And fortunately, we've had a lot of residents that are like that. We've had some that aren't, so we know characteristics are somewhat important. Education is somewhat important. How you do academically is somewhat important. And how you do in clinical questions is important. But more important, I think one of the things that we get is if we can talk to faculty at different places and we can weed out some of the ones that, well, they don't have to say, I wouldn't take this individual. All they have to say is, well, I think some of the others are a little bit better. You know, there's ways to be able to do it. And that has really been very helpful. And fortunately, we've been able to know enough people at the different schools that we sometimes can get some input and maybe save us that one individual that's very smart, but can't get along.
And it's hard for
And
us
I
to make
enjoy
those
it.
recommendations when they don't come to class.
Right. Well, that was first, I'd always look very young for my age. And so I was 26 or 27 when I was teaching. And the guy that was teaching in front before me was Guido Laporta, who's a big Italian guy and very intimidating guy. And I look like I'm 16 years old. So when I first went into class, I like to call on people. And fortunately for me, the first several times I was into this classroom with 120 students, I happened to call on people that weren't there. So they all thought that I knew who they were. And of course, 125 students, I didn't know who they were, but they thought I did. So then they started attending class because they were afraid they're going to get called out.
I
The
love
second
that.
thing that happened to me when I was teaching that helped was I started dating a young lady who was a special ed teacher. And so she taught me how to teach a little bit better. I eventually married her, so it's my wife, but the students were thanking her for dating me. So it worked out a little bit better.
That's fabulous. Well, Dr. Green, Don, we so appreciate you taking time to discuss podiatric medicine and a lot of the history. Thank you so much for joining us. And Joe's got a cup there that we're going to send you, Dean's Chat cup that you can use for your beverage of choice.
All right. Well, thank you.
Maybe we'll be able to do this again down the road because I think we hardly touched on any of the questions we had, but the time flew, like we said.
All right. Well, thank you. I enjoyed it.
You bet. And all of our listeners out there on Spotify or Apple Podcast, we'd love for you to give us a 5-star rating, but really what we're looking for is some comments. And so if you're willing to put a comment in, that'd be great. And everybody that is watching on YouTube, we appreciate you tuning in each week. So until next week, everybody, cheers.
Okay. Bye.
Don, that was fabulous. Oh my gosh.
Thank you so much.
It told you, I mean, we went 50 some minutes and it just felt like nothing.
We'll be able to cut some of that out, I'm sure.
Well, the technical difficulties don't help.
But the technical difficulty part we'll take out, but the rest of it was outstanding. Thank you.
All right.
Thank you so much. Really
All right,
appreciate it.
Don.
Nice to seeing you too, both of you.
All right. Bye-bye now, Don.